Yes, seems like we are ready. This is a valve-in-valve procedure.
You can see the slide?
We can see
We
everything.
see the valve, we don't see the
We see
slide.
so many things that we don't know what to look first. So
Okay, first,
right
let's-
now
let's talk about the patient.
we're looking at the valve and you're trying
Can
to
you
cross
come
it
up
with
with
a
the
wire.
TE, please?
Now we see
Don't
the
need
slide.
TE now.
Bring up the slide, please, with the clinical information. And we don't need to see the slide, the table, the hands at the table view. Okay, very good. So this is, we can see now 92-year-old male at the top right, the medical history.
92-year-old male, and same, presented with heart failure symptoms to the outside hospital, then subsequently found that he had his AVR. A status-post AVR with a 25 millimeter perimount valve. So the EF is about 40%, and other risk factors are shown there. So he was treated for heart failure, then sent here. Though he was 90, is a good 90, takes care of himself, and cath had shown non-obstructive coronary disease. So here we are for a valve-in-valve tower. I have myself here. I have Asad Khan, Mohammad Khan, the fellow, and the surgeon is Dr. Farzan Filsufi.
Oh, excellent. We have a professor of surgery in the room.
Normally what we do is to recross the valve, we go with the AR1 and just with the straight glide wire. But somehow we are not able to cross this valve with all the usual technique we do. So now we are with AR2 and a V18 wire. How bad is the
they can
stenosis?
go like 2 images while we cross.
Using a metal wire or a thermal wire?
No,
This is a V18.
V18 wire, but now change also the AR2. They made two changes.
Yeah.
So
Two changes.
They changed it from AR1 to AR2 and from the stiff angle glide wire to the V18 wire. I wonder if they need to go back to the straight glide wire.
No, we did.
You did
We tried
already.
all that. You can show the echo, just show not the live echo, the old echo images, and then Asad can show you the CT scan.
And the
Dr.
primary
Yunus,
pathology
can we
is stenosis or
It's a
regurgitation?
combination. It is stenosis, but a moderate AI also.
And the size of the perimount?
25.
25. So you're
So
planning
based
to put...
on
26
26
26.
evolute R. Yeah.
Yeah.
Yeah, that makes sense. And the height of the corners, I
Okay.
assume, good enough?
Show everything.
So this
And
is the
let's try to have some slides regarding the valve-in-valve app or regarding the sizing of this valve. Very good. We see it now in the factoids.
Take
Very
the
good.
T out.
no, go back one slide, please. Go back one slide. Okay, we have the measurements. So anyway, for all valve-in-valve cases, as a rule of thumb, for all stented prosthesis, perimount is a stented prosthesis where the leaflets are actually sewn inside the valve. The rule of thumb
we tried
is as
AR1,
long
AR2
as
now.
the height of the stent struts is smaller than the height of the corneosteum, you don't need to make any more measurements other than the annular measurements. However, in this particular case, the height of the left corneosteum is only 8 millimeters, and the height of the surgical stent frame is around 16. So in those sort of cases, we would make this measurement, which is called the VTC, which is the virtual transcatheter heart valve. So go next slide now. We're past this. Next one. There. So this VTC distance, as long as it's above or more than
Can you
3
do
millimeters,
fluorosave?
we have lower likelihood of left main coronary obstruction. So in this case, it's around 8, so it's pretty safe to proceed with it. Go next frame.
Well,
Next slide.
One
Yeah.
can clearly comment before you go to the axis is that this entire annulus is, you can go one slide back, the entire annulus is much bigger than the surgical valve already implanted there.
Very wide sinuses as well. So
Yeah, which is
pretty-
give you comfort zone in terms of coronary obstruction.
exactly.
Right.
Despite the height being low. So next slide, please. Yeah.
It looks
So-
like there was not a lot of gradient, so probably there is, as you said, it's a mixed disease.
Mixed AI and AS. Yeah, gradient is around 40, a peak with a mean of around 25, and then we have AS as well. So
Yeah.
iliacs are a bit tortuous, but not much. Calcium, go next slide.
So you don't
So-
use the safari wire, Dr.
No,
Kinney?
we use Confida.
No, we use for this one we'll use Confida. You saw how we crossed. Actually, we
Yes,
normally
very nice.
when Leo we
So
saw it.
after the crossing, the catheter goes a ventricle, and then the wire goes out, and a regular exchange wire goes, so the pigtail can go into the apex, and then we introduce the curved wires.
Yeah,
This is a one step. We always say nobody should cut corner here. You need a pigtail to be there so that your confida sits in the apex of the LV,
Yeah,
not
so
in
my,
the base.
so my point with the Safari is much more friendly wire, and it actually sits like a pigtail without much manipulation. So we switched
Okay.
completely from Confida to Safari. The small Safari is a beautiful wire.
Which
Should try
company
it.
makes the Safari? Which company makes?
Boston Scientific.
Okay, we'll look into that. Yeah.
Now, in this area view, always go to the area view for this manipulation.
look like
The pigtail
Give me
is,
the
will
wire.
be tried to be advanced towards the apex. With
I
or
know.
without the wire.
It's not. It looks like it's in the base, probably caught in the papillary muscle. That's
Yeah.
why it looks like. I'm
so
going
you
to go
are-
back.
Perhaps you need to reinsert the wire a little bit and come a little back and do maneuver a little bit back and forth. Come back a
Yeah.
little bit.
You don't want to lose the position of the wire because it took a while to cross.
Can we move the TE probe for a few minutes up,
Right here.
please? Yeah, good.
Don't not too much. Yeah. This one.
Okay. Oh. Uh-huh.
All
Well,
right, let's
that,
go again.
it
Recross.
snapped out, there's no question
Cross
about
again.
that.
Because
Go-
we were
right
problem.
Now, you can cross again.
Why do you need a TE for this procedure?
Just for a valve-in-valve cases, we sometimes use it, but no particular reason. Like the risk of coronary obstruction is lower. Also because in this case, there is AI, and we always try to make sure it's not paravalvular and more valvular just before the case as well. So we only had a TTE before, so that was another reason why we thought we'll just do a TE at the same time.
Directly this time. Go to LO again a little bit.
Yeah.
All right, let's go back to a little bit more LAO and slightly caudal view that was a little bit more successful to cross.
Yep.
I think the original times that the cross
LAO
was a
also
little
better,
difficult.
yeah. Give me a straight wire
The
now.
LAO was very shallow. So let's
Which
go to a
LAO?
little bit more LAO, around 30.
Good. That's
And the patient is on conscious sedation or general?
Conscious.
Conscious.
Oh, no, GA.
this one is
Cannot
intubated.
be
Because of the
considered.
Patient
The
is
patient
low
is,
EF and AI,
No, it
so
was a complex case with TE.
No, no, also waiting for the symposium
Yeah.
for us to come. Had to be ready for a while.
Just your data run. Ours is still about 80% get conscious, but 20% for various regions, like somebody like this. Ejection fraction low, of course. In this particular case, there is an issue in terms of
Let's go to
intubation.
REO.
Yeah.
Yeah, so
go
we
to
don't
REO.
do any more TEs unless there is
Yeah, we are the
no
same.
CT.
Yeah. Yep, that's it.
No, confident.
Go to the
he wants.
confida directly. I mean, confida wire down.
Well, this is definitely, you can see the elbow of this catheter went all the way to the apex. And
Yeah,
that is
you're in
now
good shape now, I
a
mean.
different story, but you have to continue push it to kind of keep it there because it wants to kind of come back.
Okay, now it also sits nicely, look like more like a pigtail.
Yeah.
Okay, so get the valve.
Okay.
And this is the Evolut R, I assume, right?
Right?
Yeah. Evolute R, yes.
Yeah, you don't need to
26.
scare it
No, we
here.
don't. And we put temporary wires through the groin as well for all the valve-in-valve cases.
And you have a pacemaker as well? Or I
We have a
haven't seen-
pacemaker, yes.
But from the groin,
from the groin.
we
But
don't
we'll
have
take
to
it
leave
out
it in. Yeah.
straight after.
End of the procedure, we'll take it out.
And we have sentinel up as well. It's a bovine arch.
And you want to show the sentinel up?
Yeah.
No,
Have you
we'll
shown
see
it?
it as we
Okay,
go.
good.
Yeah, the valve-in-valve cases usually don't
Go.
need a permanent
Go.
pacemaker. So some people would actually just space it on the
Yeah,
wire.
confida wire, yeah. We
On
have
the
done it a
confida,
few
you
times,
can
yeah.
pace it on the confida wire if you
Yeah.
want to.
We've done
Of
it a
course
few
you
times.
can, it's just that a little bit extra acrobatic for a complex case.
No, no, the problem is
One
if you
second.
need permanent pacemaker, then it's
Go.
becoming tricky. But valve-in-valve cases never, I mean, I would say never, but it's almost rare to see them needed.
Very rare. Yep.
So you
Permanent
can.
pacemaker.
So you see how easily this
No,
went
just
around
showing the sentinel.
apex and around the arch and now going towards the valve and goes into the
Ay, ay, ay.
goes a little bit more aggressively into the
Gentle,
LV than
gentle.
Yeah.
anticipated.
Okay, hold on. We have to go to the view.
All right, let's go to the implantation of you anyhow. Somehow we're in the LV.
And you can use the post of the perimount to remove the parallax.
Okay, good. You have to take the parallax out now.
Yeah, no, not the valve parallax. We go by the surgical valve, so it's good.
It's
So
good?
Surgical valve is good. LAO1 caudal, less caudal a bit.
I would
Side
go by the
response.
surgical valve to
Yeah,
make sure
we'll
you're
go by
underneath.
surgical valve. That's what we're doing.
Yeah,
Yeah.
It's okay?
Keep holding.
keep going.
So we are aiming
So
for
we're
like
going
0
to-
to 1.
We're going to start releasing now.
Are you using pacer when you're doing it?
Yeah, we will not yet, but I
Not
think
yet,
when
but-
it starts flaring.
Yeah.
So now just a little bit. Good.
Depth is
Okay.
good. Let's
Yeah,
hope it
that
stays
looks
that
good.
way.
Start
I will start
pacing
pacing
at
now because you
120.
see there was some ectopy runs here, so that we'll start pacing at about 140.
120. Still blood
120.
pressure is
120
not
is
high.
good enough, but as long as you keep it stable from arrhythmia.
The pressure is nicely below 100. Make sure it doesn't come up. It's just on the verge to pop up.
It won't. Yeah.
Go
But hold
140.
really stable right now
Pace
as it
140.
flares.
Once we're good. We're doing well.
Very good. Keep it up. Keep it up. It's diving now.
Slow,
Now
slow,
it's the opposite.
slow, slow. Don't pull too much.
So with valve in valve, you want to be as high as possible
pulling.
to
Yeah, we are pulling.
eliminate gradient post.
Just, I think,
You
capture
can get it a little
capture
bit higher, that would be better. So
Yeah.
you
A little
resheathing.
higher.
Yeah, LVUT
We're
is-
going to resheath, pull back.
Yeah, LVUT is very wide here, so we were expecting it to die. That's why I was holding it back more.
All right. So
Okay, I think we are good now.
Yeah.
Partial recapture and,
Partial
and
recapture,
continuing,
and
the-
I'm going to go back.
continuing
Releasing.
now. We have the pacemaker at
It will go.
150.
It's okay. Go. Oh,
Oh,
it's okay.
All right. Well, that's the
pacemaker.
Offer.
that's a valve-in-valve situation. When the when you want to when I aim for 0 to 1,
Yeah.
you may
We'll
end
go
up
a bit
at
deeper this time.
minus
Yeah,
1.
do full
Capture full.
recapture now
Full
because
recapture.
Just
Full recapture.
now we
I
have to
did.
proceed with a full capture,
Yeah, we
and
are.
we have only
Pull the wire
3
away.
such full captures to do.
careful, careful.
Yeah.
Watch the wire though.
Yes,
we
yes,
are.
yes.
There.
Watch the wire.
the only
Yeah, yeah.
recommendation, when you release it, just do slower than you did before.
Yeah,
All right.
we go a bit deep this time.
Watch the wire. The wire is way back.
Good.
This is like the DK crush technique.
No, I mean, but it's not a radial approach, Kinney.
I know. I like your comment, femoral approach.
Yeah. Well, we still do a lot of femoral with ultrasound guidance and micropuncture, and we don't
Okay,
see
good.
much
Yeah, we keep going.
problems.
Watch,
with it.
Pace.
watch
Yeah.
it.
140.
Watch
lean
it doesn't
forward a
jump
little
now.
bit.
Very slow release. Go
Yeah.
to pace, please, at 140 or 150 something. Yeah,
And
No, I
very
did
good.
140.
Lean
Pacing
forward.
now.
Lean forward with the
Yeah,
device.
yeah.
Who's holding up there? Is
Yeah,
the
that's
Dr.
okay.
Khan?
Right now you're good.
Dr.
Dr.
Khan is
Khan.
holding.
Keep a little
Slow.
nice pressure.
Slow release.
Okay.
Very
Slow,
slow.
slow. Yeah, we're good.
Release
Slow.
and pull up now. It's
Slow.
I am,
diving.
I am.
No, don't pull.
It's diving.
He's diving, he's true.
Push
Come
the
up
wire a
on the-
little bit. That would
Diving.
help you.
Push the wire. Yeah.
Push the wire in.
Diving.
Yeah, I think
Okay,
he's
we are
hitting them.
controlling it. Okay, now it's
It's
better.
going down.
Yeah.
It's not, it's a very bad parallax, I think.
No, no,
Very
parallax is the surgical valve. It's
No, I
okay.
know, but it's
Okay,
not.
good, better. This is
Keep.
better.
Now it jumped up a
Better,
little bit. That's
better.
good
Push-
to your
push
benefit.
forward.
Keep it up.
Pushing.
Push forward.
Keep it
Yeah.
up.
Okay, stop pacing. I think we are good, we have to release. Remember, I am almost ready to release.
I think-
Quick,
Keep there. No, wait a little bit until the rhythm stabilizes.
Just take
Okay.
a
we are
Pace
ready
at
to release.
60.
Yeah.
Yeah, or
I think
yeah,
you're in good
pacing at
position.
Yeah,
80.
we're in good shape.
Yeah.
Pull the wire back slightly. Center.
Yeah, pull the wire back a little bit,
Good.
and then do very, very slow release.
Okay, I know. I'm slow release.
Keep going.
We are pacing.
All right, make sure you are with a push a little bit, Dr. Khan.
I am.
Pace at
Lean forward a
120.
little bit, that's all.
Very low, slow
Lean
We're all
release.
forward.
leaning forward.
Your enemy is going to
Lean
pop
on
up.
it.
So
Lean on it, Dr.
forward
Khan.
and pull some wire.
Lean on it.
Good.
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 You're good.
Perfect.
You're
Worked
released.
out perfectly, and the cone came out.
You put your TEA probe now, please.
Beautiful.
Okay.
Watch the
Hopefully
wire.
things look good. We are not going to post
Pace
it.
at 80 or something now.
Yeah,
Wow,
you don't
we're
need to
doing
pace
this.
anymore.
Stop pacing.
Just take a little die so that I can go.
Thank
further.
you.
Okay, we'll do a quick aerogram as well.
But it would be nice to see, I mean, you have to see that there is no gradient here. I know you have the echo.
Good.
We're going to go in the LV with the
Yeah, we'll
pigtail.
go,
Absolutely, we'll
Yes,
go.
Nice.
no,
And you
no
can,
AI.
and we can clearly see
Okay,
that.
show the TE. How does it look?
Yeah, it shows no minimal paravalvular leak.
Yeah, the only
Dr.
issue is gradient because
Dr.
it's
Lerakis
slightly
at the
low.
DE.
What
Yeah.
we'll do is we'll go in and do the gradient. Take it out.
Yeah, I can
We'll
do
go
the
with the
gradient.
pigtail.
On the other hand, you can see how gigantic this aortic root and aortic ascending aorta is. The core valve doesn't touch
We are going to
the,
show you a gradient and then
the,
you can move on to the next case.
doesn't touch the aortic wall.
There's a pigtail.
Okay.
Oh, don't you
I
think
mean,
that's
the-
a bit of a microscopic there? We cannot see this valve.
No, we are trying to take the valve out, so we are keeping the tip of the wire in view.
Can you show us that I thought you would say that you want to visualize the
wire,
distance
push the
protection,
wire.
make sure you don't knock that off on the way
No,
out.
that was already past that. The valve was pulled past that after the deployment.
Okay, now we'll go with the pigtail, get a gradient. Hopefully no gradient. And this is the valve.
But
Core valve is the valve to be you're done for valve in valves. In supravalvular, you get a very better hemodynamics.
So
And
with
for
the,
92, it's good for another 10 years, right? So it's,
for the supraannular position, you get a bigger
Madam.
valve than what you get inside the.
Moon.
Bigger
Inside the
valve,
old
so they
valve.
can see it. Yeah, go.
seven
I think
by
it's a
echo.
ninth position. He's saying of echo is giving a gradient of 7. Let's see with the hemo.
7 by mean gradient by echo.
I don't need to see, I tell you, it's 0.
because,
We need a pigtail.
okay, so you have
Are
to,
we sure seeing the hemo there right now?
Yeah, 0.
Yeah, well, then make sure you flush both channels.
Flush and re-0
and
if you
good
need.
0.
Yeah, re-0. Another re-0.
Is
This
there,
is all
another,
dye.
is there another channel? The red channel always has dye, doesn't work very well. Or make that LV.
Okay, look at that.
There, you have the hemodynamics?
Same,
Oh.
like a 6
Yeah.
to 7.
Yeah, that's good. You don't have to do anything with that.
Yeah.
And
Everybody's
the
saying
diastolic
it.
pressure is about 65, which is good. Systolic pressure 180.
What did
Make
the
sure
echo
it's
tell you
unchanged.
about the gradient?
5
They're
to
showing
7,
it.
yeah.
Can you show the echo?
Yes.
They got a mean gradient of 7, peak of 14.
Yeah.
And you can see the LVDP here is very low, is around 15. So
Yeah.
it's a
Yes.
great result. Great result.
Okay,
Yeah.
good job.
It looks good.